Good afternoon and welcome to this month's Northern Virginia Health Policy Forum. My name's Jim Scott. I'm the president and CEO of Applied Policy, a health policy and reimbursement consulting firm in Alexandria, Virginia. My colleagues and I host these monthly gatherings to explore issues shaping 21st century American healthcare. On a special note, Applied Policy is hiring, so if you'd like to join our team, please let me or one of our team know. Our guest today is Dr. Arlene Bierman, Chief Strategy Officer at the Agency for Healthcare Research and Quality, or AHRQ. I had the pleasure of getting to know Dr. Bierman through my work with the Alliance for Aging Research, and the work that AHRQ does is very important, and we wanted to make sure you know about it. AHRQ is currently celebrating its 35th anniversary of conducting research designed to shape the future of American healthcare, and AHRQ and Applied Policy both share the goal of improving lives. Dr. Bierman is an internist and geriatrician who's dedicated her career to improve the access, quality, and outcomes of healthcare for older adults with chronic diseases and underserved populations. Dr. Bierman's going to start off with a brief slide presentation, and then we'll follow up with questions and discussions. So if you have a question for Dr. Bierman, please chat it, and I'll work it into the program as I'm able. So turning it over to you, Dr. Bierman, welcome.
Jim, I'm very pleased to be here today. And first, I'm just going to tell you a little bit about AHRQ, because some of you may be familiar with us and others may not. But AHRQ is an agency within the U.S. Department of Health and Human Services, and our mission is to produce evidence to make healthcare safer, higher quality, more accessible, equitable, and affordable, and to work with the department and other partners to make sure that evidence is understood, and most importantly, that the evidence is used. And some people wonder where AHRQ fits into the, alphabet soup of U.S. health agencies. And just to make, to show where we are, that NIH finds cures for disease, what AHRQ does is really focus on the science of care, that we really can learn how to effectively improve the care we deliver. FDA focuses on drugs, and CDC on public health. And so AHRQ's basically, our goal is to improve the lives of patients. We want to help healthcare systems and professionals deliver care that is high quality, safe, equitable, and high value. And the way we do this is through health systems research, supporting practice improvement, and actually providing data and analytics. And, one thing that this also distinguishes AHRQ from our sister agencies is that our really focus is person-centered, and also focused on health systems. And, by person-centered care, we mean that individuals' values and preferences are elicited, and once expressed guides all aspects of their healthcare, supporting their realistic health and life goals. And person-centered care is achieved through a dynamic relationship among individuals, others who are important to them, and all relevant providers. And this collaboration informs decision-making to the extent that the individual desires. So now I'm going to go fairly quickly through a number of slides just to give you an idea of the resources and what we offer. And these slides can be available with links if you want more information on anything that's on them. But AHRQ is also the lead federal agency for primary care research. And we house the National Center for Excellence in primary care research. And we know that strengthening primary care is really key to making our health care system more high value and more high functioning. AHRQ has many research. We fund research. We're like NIH, but we fund health services research. So for those of you who are interested in research, I encourage you to go on our website, look at our funding opportunities. And these are just examples of funding opportunities to advance the science of primary care. We also provide a lot of tools and resources for practice in health systems improvement. We host the Integration Academy, which has a whole host of tools to help people improve the integration of behavioral health and primary care. And just as an example, we have a whole host of resources about managing unhealthy alcohol use in practice. And also we have a new really change package for improving management of opioids in older adults, which I'm sure you all know is challenging because of the high prevalence of chronic pain, the higher risk of adverse events from opioids, and really an under recognition that even older people can abuse substances. So this page has a host of resources for people who are interested in this. And we have many resources on many other topics. This is just to give you an example of the kind of things we provide. And this is a very exciting. There was a commentary in JAMA last month. And through the Patient-Centered Outcomes Research Trust Fund, AHRQ is getting ready to fund state-based, at least 15 healthcare extension services. So these will be state-based collaboratives aimed to support primary care and improving the care delivery in their states. And the purpose of this is to accelerate the dissemination and implementation of evidence into practice, to reduce healthcare disparities among those who are disadvantaged. And so there was a notice of information to publish notice of funding opportunity that was released on June 6th. It's available on our web, but essentially we're going to be funding the state-based healthcare cooperatives, a national coordinating center, and a national evaluating center. So if your states might be interested in this, please, keep an eye out for the call for proposals. And now I'm going to switch gears a little bit and talk about a topic that's near and dear to my heart, the aging of the population. And I think this is the biggest, stealth problem that was not getting enough attention in our healthcare system. And this is a priority for AHRQ. And we know that, the US population is aging, lots of talk about aging in the news these days, but our health system is really unprepared to take care of the aging population. And just to know, the population over age 65 and older increased from 40 million to almost 56 million in 2020. And it's supposed to reach almost 95 million in 2060. And life expectancy, we're not doing well. Life expectancy and active life expectancy, which is the number of years you live without disability, are declining. And inequities on these measures are widening. So I think there's some urgency in tackling this. And there's actually a lot we can do to improve care and reverse these trends. It's also a health equity issue because people who are low income and minority individuals age faster. And also we know that much of the morbidity and mortality is preventable. So there really is a lot we can do. The other challenge is multiple chronic conditions. The two are related, but not totally overlapping. And basically, 1 in 3 adults in the US have multiple chronic conditions, and 4 in 5 Medicare beneficiaries. And I call this a stealth syndemic because it's upon us and we're really not giving it the attention it deserves. And so basically to address multiple chronic conditions, we need disease-specific, as I mentioned, we need patient-centered approaches versus disease-specific. And we really need to deliver whole person care. We need data to be able to do this. And we need interoperability of our data sources in order to provide shared, comprehensive, integrated, coordinated care. And I mentioned earlier, it's a health equity issue. And just to give you some numbers, that people with multiple chronic conditions, 64% of all clinician visits, 70% of all inpatient stays, 83% of all prescriptions, 71% of all healthcare spending, and 93% of all Medicare spending. So you can see how the value in addressing this. So AHRQ has developed a strategic plan to advance health system transformation to optimize health functional status and well-being among older adults. It will be posted on our website soon, but I just wanted to tell you our vision and also use this as an example for other priority areas for AHRQ, how we work. So our vision is that all Americans receive high-quality, person-centered care based in primary care that optimizes their health, functional status, and well-being as they age and advances health equity. And the way we do this is we support health system transportation by funding research. I mentioned this earlier, but basically to develop, implement, and evaluate and scale models of care to do this. We also disseminate and implement evidence in practices so to increase the uptake of what works. We also support training and mentoring of health services researchers. We have a new round of P30 grants that are training embedded researchers in health systems to be able to do this. We're working very within AHRQ to really create synergies across all our AHRQ's portfolio in this area, like any other big organization. Sometimes every center doesn't know what all the other centers are doing. So we're really working to align our work. And we're also developing strong federal health system, public health, and private sector partnerships for this work. And why this is so hard, we held a roundtable on aging last April, and a lot of discussion, what will it really take to perform, transform care? And there was a big discussion, do we need policy or do we need the payment? Because currently payment incentives aren't aligned for this type of care. And it was clear that we need both. But in addition to that, what we're really talking about is, culture change and bringing the caring into healthcare systems and really being person-centered and holistic. And then we need the evidence, we need the research to know the right way to do this. And there's a very small sweet spot to align all of those, but that's what we're working on. We had a special emphasis notice on a funding opportunity for health services research to improve care for older adults. And this special emphasis notice conveyed AHRQ's interest in supporting health services research to conduct research that addresses questions related to the development, implementation, evaluation, and scale of person-centered models of care to optimize physical and mental health, functional status, and the well-being of older adults. And so we have an exciting initiative now, actually funded through the PCOR Trust Fund, which is called Person-Centered Care Planning for people living with multiple chronic conditions. And what we're doing with this is we're gathering knowledge about the current state of care planning across the country. We're identifying innovative, feasible models. We're identifying innovative digital solutions, and we're identifying key organizational policy, payment, technology, cost, and resource requirements and levers to make this happen. And this work will also identify key research priorities, strategies, recommendations, and next steps for to support our mission. And I should say this work is being done through a contract with our action network with Oregon Health Science University. And it includes a leadership roundtable as well as a learning community to really accelerate learning and problem solving. And I believe this is my last slide, but I just wanted to say how this work is so well aligned with the current administration and department priorities. The White House released earlier this year a playbook to address the social determinants of health, which talks about how health systems can work to address the health-related social needs of their patients, but also how communities can create environments where people are healthy and thrive. There's also another group working across HHS, which is advancing the use of community care hubs. And community care hubs are basically organizations that align all of the social and community services in a community. And then they can interface with practices and health systems to be able to make sure that their patients, if they're screened for social needs, they can get those needs met. And following on that, we put together a call to action to address health-related social needs in communities across the nation, which is very simple. It basically lists what could health systems do, what could professional societies do, what could communities do to move this agenda forward. And also very exciting, the first ever report to Congress was done by the Interagency Committee, which I serve on, for healthy aging and age-friendly communities, which presented a strategic plan for framework for a national plan on aging. So I think there's a lot of momentum and a lot of information moving us in that direction. So these slides will be available. You'll be able to click on all of these links for, if you want more information on any of these. Next slide. Oh, so actually there were a few more things. I continue to do research, and I'm working in partnership with NIDDK on a project funded actually by ASPE to develop an interoperable shared electronic care plan. Because the other thing that AHRQ does is develop tools to be able to improve care, including digital tools. And what we're doing is developing an interoperable electronic care plan to facilitate aggregation and sharing of critical patient-centered data across home, community, clinic, and research-based settings. And the reason I'm sharing this with you today, it's exciting. If you look why it's so hard to give comprehensive person-centered care to people with multiple chronic conditions now, is right now they see multiple providers, multiple EHRs, and their data is all over the place. And the poor clinician, patient, caregiver are, really the ones who are the glue that holds it together, gathering all this information, where ideally all patient data would be in one place and shared by everybody. And then this data could be used for multiple purposes to improve patient care, shared care planning, but also for research and quality improvement. And just as an example, this is a screenshot of we've developed a couple of apps. And what we do is we also collect goals, patient goals and clinician goals, to start a conversation for how to make people as healthy as possible. So that was my last slide. And this is not, this is challenging. And I'm going to end with a quote by Antonio Machado, who is a Spanish poet, but he said, "Traveler, there is no path. We make our path by walking." So I think all of us working together, we can figure it out. Thank you.
Well, thank you very much, Dr. Bierman. And we really appreciate you sharing with us the advanced copy of the detailed strategic plan. And in it, at the very beginning, it says the problem. I'll read this. The U.S. population is rapidly aging, and the health system is ill-prepared to meet the needs of older adults. Older adults and individuals with multiple chronic conditions frequently receive fragmented and suboptimal care, leading to poor outcomes, including avoidable adverse events, hospitalizations, and institutionalization, as well as increased costs, negatively impacting the sustainability of the Medicare and state Medicaid programs. So with that, I was hoping we could unpack that a little bit, because I know that this statement of the problem doesn't come lightly. It's probably based on research and findings of AHRQ's prior work. So what evidence do you have that, can you give an example of the kinds of suboptimal care that you found that older adults are getting?
There's so many different ways. And the other thing is, why we don't do better. And I think there's a lack of awareness of how much we can do and how much is preventable. And thinking about what I'll go into in a minute, some examples of how what the problems are. But I think some of the reasons is, I think there's lack of awareness just about how big the problem is. I think people get overwhelmed. I think there might be nihilism, like, oh, this is so big, there's not much we can do about it. I think there's also a lot of ageism in the system, like, oh, you're just getting old, and not realizing that, being frail or sick is not synonymous with aging. And I think there's also a lack of awareness of the return on investment for getting this right. So we actually have a lot of evidence for models that work. Some of it AHRQ funded, some of it not. But for example, there was a GRACE model that in Indiana that provided support to primary care practices to better take care of their older adults. And they had a randomized controlled trial, improved outcomes, improved quality of life. And it's been hard to scale because of the way we pay for care. There was another intervention called Capable that was funded by CMMI, where they allowed people to make modifications to their homes to allow them to live in the community and not go into nursing homes, which also reduced institutionalization. Again, that's something that's been hard to scale. We have the PACE model for taking care of people who are eligible for nursing homes in the community that's been very successful. So we do have a lot of evidence for solutions. What we don't have is the evidence is how do we make these mainstream and how do we scale them? For example, the GRACE model, the state of Indiana really tried hard to scale it across, the state, and it was payment barriers that made it very challenging. But the other thing is we have lots of studies on adverse outcomes in people because they get fragmented care, avoidable readmissions, avoidable morbidity and mortality, avoidable institutionalization. So there is this is a place where we have huge evidence. Also in terms of cost, duplication of services, when you're being seen by different providers in different systems, how many times do you get the same tests over and over? And that adds cost to the system. There was actually this really good economic analysis that was published in Nature Aging that showed if you could delay, if you could extend active life expectancy, so your years without disability, by 1 year, it's worth $37 trillion a year to the US economy. So we can make the case for doing that. I think we need to figure out how to educate people about the opportunity that's here.
Great, thanks, Dr. Bierman. And then building on that, you mentioned avoidable adverse events, or the plan does, hospitalizations and institutionalization. What are the kinds of avoidable adverse events that you've seen? I know you said morbidity and mortality, but could you be like a little bit more specific and give us an example that we can apply to real life?
Sure. You know what? I think I'm going to start with drugs because polypharmacy is a big problem. And, people's also physiology changes as they get older. So there's also drugs that have like more adverse side effects in older adults than younger adults that should be avoided. But because people have multiple diseases, people often take 10, 12 drugs, it's called polypharmacy. And there's drug interactions and side effects. And there's also something called prescribing cascade, where you're given a drug for something, it causes a side effect. And rather than stopping the drug, you're given another drug to treat the side effect of the first drug. And I'll actually tell a personal story. So I practiced geriatric medicine for many, many years. And I actually supervised residents in the general medicine clinic because I felt there was a need for general internists to have more geriatric competencies. And I was in the elevator in the hospital and I ran into one of my former residents and she was now a GI fellow with her attending. And she said, "Oh, there's Dr. Bierman." She goes, "I was in clinic with Dr. Bierman for a year and all we did was stop medicine and everybody got better." So I think we have, it's a good example that if we also need to raise competencies across the whole healthcare workforce for anybody who, treats older people, to be able to, provide better comprehensive care. And the other thing is another area where there's been a lot of advancement. This is work that's been done by Mary Tinetti on patient priorities care. So when you're starting to get a little older and frail and you have 4 or 5 conditions and, maybe the one drug for one condition interacts with your other condition, how do you set your priorities? And so this is to give interdisciplinary teams and practices the time to sit down and talk to people and say, what do you want to achieve and how can I help you achieve it? And tailor shared care planning so that the care you're getting really helps you meet your needs.
Thanks, that's super helpful. So also in the strategic plan, it says that improving the health of older adults requires re-engineering our primarily disease-focused sick care system to one that's person-centered, delivering whole person care across the life course, aimed at improving the health and well-being of people and populations in the context of their lives. And I was hoping, I know in your presentation you mentioned person-centered, but I was hoping you could explain, more specifically what needs re-engineering? Like, what are we doing now that needs to be re-engineered?
So I think number one, we need to invest in primary care. I mean, if we talk about evidence, systems that are based in primary care have, better health outcomes, improved access, better quality of life. And our primary care system in the US is really on life support right now. And that's central. You need a primary care doc who can help coordinate all your health needs. But one of the things you need to risk stratify, and one of the things we talk about at AHRQ is one reason we have such a crisis of multiple chronic conditions is it's the same risk factors for every disease, right? If you think about it, physical inactivity, heart disease, dementia, right? Osteoporosis. So if we could, so if we have a life course approach that integrates public health and primary care, that focuses on prevention, better chronic disease management, we could really make the population much healthier as it ages.
Thank you. And then at Applied Policy, we work a lot on the Medicare program. The Medicare program is, CMS is obviously limited by the statute, and the statute says that Medicare can only pay for items and services that are reasonable and necessary to diagnose or treat illness or injury or improve the function of a malformed body part. And what it doesn't mention is screening, risk stratification, prevention. Over time, Congress has added specific, benefits like colon cancer screening, but it's one at a time. And then the U.S. Preventive Service Task Force, CMS is allowed to adopt their recommendations that get an A or B rating, but it seems like the U.S. Preventive Services Task Force isn't looking at what does prevention and mean for people 65 and over. They're looking more broadly at what in the United States means prevention. So I wanted to get your thoughts on how the current statutory mandate seems to run counter to what you're telling us. We need more screening, prevention, risk stratification, and that kind of thing.
Yeah, no, and I think Medicare is very aware of this. And, just for, the people who are on the meeting now, AHRQ does support the U.S. Preventive Services Task Force. And Jim, it actually does look at stratifies and sometimes looks at recommendations across older adults and looks at problems related to older adults. There's recommendations on fall prevention. There's recommendations on osteoporosis, on urinary incontinence. So there is a lot that they do for older adults. And I would say that Medicare does enable a lot of this under its current programs. And then there's a lot of the move to value-based purchasing is going to let this happen even more. So I think underused is the Welcome to Medicare visit, which really encourages this. Medicare pays for chronic disease management. And a lot of this is related to improving chronic disease management. And Medicare also has added new codes over the last few years for care coordination and some of the things that you need. And to do this, the challenge, I'll be honest with you, is that patients have a copay for those codes. So they don't want to pay those copays on top of, so if there's a way to maybe, make those services more accessible and remove some of the financial barriers. But then also, if you look at like ahead, there's a lot of new models, make care primary. Medicare is really working to fix this. Some of the ACO models enable this. And I think really exciting is the newly released guide model that, was awarded just this last month, I think. And that's for people living in the community for Alzheimer's, and they're testing adding on other services, adding on the comprehensive team-based care for people with cognitive impairment and dementia, as well as, giving services that were not previously covered, like respite care. for their caregivers, because we know that, caring for a loved one who has high needs actually impacts the health of the carer.
Yeah, I hear you. I can understand why the co-insurance for care coordination management is hard for patients to swallow, because that's a service that operates generally behind the scenes where the patient didn't feel like they got anything. But the only thing they're going to get is a bill. So although it's necessary, I definitely understand how the optics make that hard for patients to say they appreciate or want care coordination services.
But also it's affordability. They're already paying their copay for the visit. So many don't have any other money to pay for any additional services.
Exactly. So also you mentioned some of the new codes. Some of the things that CMS has started to pay for are about social determinants of health, like a needs assessment. Can you tell us a little bit more about, I understand AHRQ has a social determinants of health database. You mentioned what you're doing on social. How does that all connect to, this opportunity for physicians to bill for doing an assessment for social determinants of health needs?
So yeah, AHRQ social determinants of health database is a very valuable resource, and it's national, and you could drill down to local levels, and it gives you, so you could do area level work understanding the needs of different communities, and it's easy to link it onto any data set. So that's the other thing that AHRQ does that I didn't mention, is it provides a lot of data for analysis. So we have the social determinants of health, a database. We have MEPS, the Medical Expenditure Panel Survey, that provides really important information on use of healthcare services and costs across the country. And we have AHRQ, which is a national hospital discharge database, where you could compare, states. And we also included in that is emergency rooms, ambulatory surgery centers. So AHRQ does, for those of you who want data, take a look at our data resources. And actually, talking about things that we funded, actually tomorrow we funded a series of grants at the request of Congress on how to enable primary care practices to do better chronic disease management by addressing the social determinants of health. And we funded 3 projects across the country. One was in San Diego in partnership with UCSF, where they created dashboards for primary care practices. So you could pull up, oh, I have diabetics. Which ones of my diabetics are food insecure? And then they linked it to the community information exchange in the community. So then you could make direct referrals and to a food bank or food services or SNAP. So I think there's a lot of innovative solutions to help people. I don't think that healthcare systems, there's a huge social safety net out there that health systems don't have to recreate, but they need to know that it's there and access it. I'll give you another example of that. I mentioned our aging roundtable, where ACL, the Agency for Community Living, funds area agencies on aging and communities across the country. And they're available to provide, services to elders in the community. A lot of clinicians don't even know that they exist or don't know how to access them. So part of this is education, not for healthcare to start making the capacity, but to know, what's in their systems. But then the other 2 projects that we funded under this call one was Kaiser Permanente, who developed actually algorithms to risk stratify. So part of this is capacity. You need the capacity to be able to, who needs extra help? And you can't do it for everybody. So they actually developed algorithms to be able to identify which of their patients would benefit for better care management services, and then provided the care managers with access to a database on the services that are available for referral. And then the last one that we funded was Denver Health in Denver, which was different, where they were working with people post-incarceration, returning to the community. so that, they could, and also people with substance abuse, so that they could share information and people could get plugged into services and Medicaid when they left, when they were released and went back to the community to help make that transition smoother. So I think given technology, given the growing evidence, there is just so much we can do.
Thank you. And building on the substance abuse, you mentioned the focus on avoiding the use of opioids. CMS recently announced or proposed in their hospital outpatient department proposed rule, a program that would essentially pay more for the use of non-opioid alternatives, but it's limited currently by Congress to post-operative pain. I know your focus has been chronic pain. Are there ideas like that AHRQ looks into to see if they think, well, okay, the cheapest thing in the world to do is prescribe an opioid because they're all generics. Anything that's made that's a non-opioid alternative probably costs more than an opioid. So when we look at costs in that sense, it seems like it's going to cost some money to avoid opioid use, and not just for post-operative pain, but also for chronic pain. So is that the kind of thing that AHRQ thinks about?
So actually, AHRQ, as we mentioned, we do evidence reviews. So we synthesize the evidence. And we did an evidence review on non-pharmacologic or non-drug approaches to pain management, and found things like physical therapy and even acupuncture are just as effective as the opioids. And actually, I think a leader in this is the VA, the Veterans Administration, through their whole health program, which is really doing mind-body work and giving alternatives to pain control. And I'm not sure you could say it's cheaper, because in the long run you have the complications. If you're on opioids and you have a fall and break your hip, well, that's pretty expensive. If you have on opioids and you have some mild cognitive impairment and you get confused and you forget to take your heart failure meds and end up in the hospital for decompensated heart failure, that's expensive. So I think we need to really think about what are the costs, and also what are the costs in terms of quality of life and people being able to engage. When do we get value because we're improving quality of life?
That's great. I think that really makes the point that the health system's fragmented. So the primary care, you have a focus on that, but they're not the hospital. So, and they're not going to feel the cost down the road. Of course, they don't want their patients to get hurt, but really, their view is, this patient came to me and said their back hurt, what are my choices? So, so it's AHRQ that has to see or get others to see that it's the broader cost to the system. You can't just look at the cost in the physician office or the cost in the hospital outpatient department and have silos like that.
No, Jim, you're absolutely right. And there's so much work being done on total cost of care. And actually, Maryland has been a leader in this, and in the state of Maryland has done a lot of innovative work on how do you actually look at the total cost of care to see what is of value and what is not. Right.
And then what are some of the key needs of older adults and their families that's a result of the mismatch that AHRQ identified? If you just give some concrete examples, I know you said care coordination, home modification and things, but kind of like you did on the polypharmacy, if you give us sort of an illustration of what older adults need that they're not getting, that a better match would help with.
So yeah, I have a great example. So this is one of the things I mentioned, our e-care plan, which is designed to help with, because actually, sometimes patients or caregivers, they're the ones who are running around and getting the results of their tests, or what did this doctor say? What did that doctor, and trying to put it all together. or a good primary care doc. I remember, when I saw patients, I would spend as much time after the visit, if not more, trying to figure out everything else that was going on, to get a test from another hospital or figure out where this certain drug came from and why they were taking it. So I think, digitally, their solutions, but to get everybody on the same page, and I'll give you an example. So, if somebody has chronic kidney disease and heart failure, which is a very common combination, they might go to their cardiologist who says, you know what, you really should restrict your fluids because you don't want to be, your legs to swell, you don't want to get fluid overloaded, you don't want to get into failure. And they go, okay. And then they go to their nephrologist and says, you know what, you have kidney problems. You need to drink enough fluid to perfuse those kidneys. So what does a poor person do? And how do we make a plan that puts that together and balances the need for, perfusing the kidneys and not being too fluid overloaded? So I think that's, with technology, with our e-care plan, everybody, the primary care doctor, specialists, can all have access to all that integrated information and have a conversation for this one patient. What is the best balance of these things? But also the patient's goals and their priorities. The patient's goals is like, I want to be able to walk around my block, go out independently and not be so short of breath. Whereas the clinician might have like a physiological or the result of a lab test or want adherence. And so our app actually allows clinicians to put their goals in, patients to put their goals in, caregivers to put their goals in, to start a conversation to how do you balance these things. But this also, you can't do this in a 10-minute visit. We have to give clinicians and teams the time to talk to people to be able to do this. I remember I was very fortunate when I started practicing. It's like when we had time to talk to and listen to patients. And as visits got shorter and shorter, I felt like, oh, I might miss something. I didn't, have enough time to, ask all my questions or do all my physical exam tests. So what would I do? I would do more referrals, and I would do, to make sure I didn't miss anything, and order more tests. And I was maybe costing the system more and delivering worse care. And I think, that has gone to the extreme now. So I think we need to actually, as a matter of fact, AHRQ developed something called the care and learn model. So we all want learning health systems where, evidence-based, data-driven, continually improving. And that's like a key function of healthcare delivery. But the other is caring, that our basic, goal is to care for people and make them feel better. And how do we put the care back into medicine? I think it's a huge challenge.
Right. We've talked a lot about older Americans, and I'm afraid I may have made an assumption, so I want to ask it as a question. When you talk about older Americans, are you talking about the Medicare population that's 65 and over? Is sort of there a bright line for older Americans, or is it something different?
No, there is really not a bright line. We use 65 because that's the age, for Medicare. But honestly, there's really inequities in how people age, depending on their life circumstances or occupations. And there's actually a theory called weathering. If you think about, you have shingles that, outside, and they're hit by the rain and the snow and they age faster, right? So, people who have, low incomes, not access to healthy food, maybe not access to healthy places to exercise, they age faster. So there could be people 50 or 60 who've had a hard life who are actually, more ill than people who are 80 and have, led an advantaged life and are doing just fine. Thank you. So I think what we really want is a life course approach. And actually, when we talk about multiple chronic conditions, we always talk about prevention and management of multiple chronic conditions. And really, prevention is a life course thing to, as you age, but especially I think we have a lot of opportunity in midlife, because what you do in midlife affects how you age, and we don't want to wait till you're very sick and frail and 65. We want you to be healthy when you get there.
Well, thank you. And you mentioned the weathering idea. I noticed that the gap in health disparities, and both racially, ethnically, and economically, seems to be widening. Why is it widening when more people have access to health insurance than ever before?
That's that's $1 million question. I'm not sure I don't know that there's one answer to that. It's probably multifactorial. But I do think that our system is failing to meet the needs or prioritize the things that would improve health. And I think there's simple things that can do that are actually not that costly, that could have a huge return on investment. One of them I mentioned before is strengthening primary care. The other is really integrating public health and primary care. And a good example of that is we've been successful a lot in smoking cessation. There's still disparities, but that's because, we have clinical preventive services and screening for smoking and treatment in doctors' offices. We also have quit lines and public policies that have made cigarettes more expensive. So can we align, public health and clinical care to have a bigger impact? And then the third thing is really integrating our health and social care system so people get what they need. And also an increased focus on prevention and chronic disease management to prevent, we know so many people, for example, with diabetes or hypertension. We've been trying to improve, if you could improve hypertension control, that's a simple thing. We have the Million Hearts from the CDC. We would prevent heart failure, strokes, dementia, and we're not even good at controlling hypertension.
It's a little bit gloomy, but thank you for sharing that. And then along those lines, it seems that a lot of these problems that people end up with are, like you mentioned, physical activity, but also the American diet, and and that causes a lot of things. Has AHRQ looked at, there's a lot of buzz about food as medicine and programs like that. Has AHRQ looked into those as part of what your work?
Yeah, I don't have them offhand, but our EPC program that does the evidence synthesis has done quite a bit of reviews of different information. And actually, they did a review several years back on the impact of, SNAP, and found that it actually does improve health when you give people the ability to buy a little bit healthier foods.
Right. And sort of getting close to the end here, but I also noticed a focus on digital health. And I know that AHRQ has developed its own apps, but it seems like healthcare more and more involves, apps that can go on your iPhone or Android. And then there's a big buzz about artificial intelligence and the promise of that. And under the Medicare program, there's no benefit category for apps that aren't associated with a physician service or some other kind of thing that's covered. Is AHRQ looking, as part of its digital health focus, into the role of apps and artificial intelligence?
Oh, absolutely. Actually, stay tuned for, funding opportunities in those areas. We support a lot of clinical decision support, but, I should have mentioned earlier, actually, AHRQ has the Prevention Task Force app that anybody could download. As a matter of fact, I went for a checkup and, they said, do you mind if the resident sees you? And of course, a former, faculty, I said, yeah, that's okay. She came in and she had the task force app to see what preventive services I need. But people could download that too. And when you go to your doctor, you could decide which are the ones that you want. And if you put in your age and sex, it'll tell you, what services are recommended now. But in terms of AI, actually, AI has a lot of problems and a lot of promise, and it has to be done right. And I think that's all playing out now. We actually worked together in response to an inquiry from Congress, where we developed guiding principles for our, algorithms and artificial intelligence applications to mitigate bias. So there are steps that we can take to make sure that, all these applications actually, are beneficial and mitigate the harms. And we can also use these apps to also mitigate disparities. So, but the devil's always in the details. What are they and how are you going to use them? But that's what AHRQ is for, is to provide the evidence about what works.
Well, thank you, Dr. Bierman. Before we close, I'd like to see if you had it's been a really great discussion. Is there one thing that you think the audience, if they can't remember anything else about what we said, that they ought to take away from their conversation that they can say they learned about AHRQ today?
Yeah, I think to understand that there is a science of care, that we need to figure out, we have the science of what works to treat each diseases, but there's also a whole science on how to deliver healthcare to be able to, optimize outcomes. And I think to realize the potential of that work and the necessity of that work, and also I think to understand the crisis of aging in this country, and that we can't put our head in the sand anymore. And there's a lot we can do, and we should just all, roll our shirt sleeves up and begin to tackle it.
Right. Well, that brings us to the end of this month's Northern Virginia Health Policy Forum. Thank you, Dr. Bierman, for sharing your insights on AHRQ and joining us today. I also want to thank the members of our audience for joining us today, and our applied policy team for putting this forum together, especially Marlo and Annie. And also, we're hiring at Applied Policy, so please get in touch with us if you're interested in being part of the team that creates this. And we hope you'll join us for our next forum in August. Stay tuned for more information on that. And then before I close, we just sent a message in the chat with links to subscribe to our monthly newsletter. You can view our Northern Virginia Health Policy Forum website. And we recently launched a podcast that is worth a listen. So thank you for being part of our presentation today, and enjoy the rest of your day. Thank you.